Okay, we're back, and we've got some, this is the picture you saw before, and now we can share some, important information. Something that is, really great is that our partners in Yerevan in Armenia shared our Congress. They were with us 1 year ago in the International Student Congress, and they were so excited about our workshops that they decided to do it on their own in Armenia. And that's just, really great and everything, because it's difficult for us here in Austria, but it's even more difficult in a country like Armenia. And they, are doing something like Sono for you there, and it's just really amazing. What we can see here are pictures from Zurich, from our partner university there, and they're watching our live stream right now, and we're happy to have photos from them. So enjoy that. Okay. Our next lecture will be given by Aidan Baron from Sydney, Australia. His specialty is paramedic performed ultrasound and evidence-based practice education. He's currently employed at 2 different universities in 2 different countries. In Great Britain at the Kingston and St. University in London, and in Australia at the Charles Sturt University. In London, he's an honorary researcher in the Emergency, Cardiovascular and Critical Care Research Group. And in Australia, he's a sessional academic in the fields of paramedicine. He has worked as a paramedic in 3 different countries and taught point-of-care ultrasound internationally. And now he is with us in Graz, which is a real pleasure. And let's have a round of applause for Aidan Baron and his lecture about the clinical background of the eFAST protocol.
Thank you so much. So, do I say Guten Tag or Guten Morgen? Or? My German's very bad. Awesome. Patrick, can I have a hand? Fantastic. Yeah, come on up. So, it's wonderful to see you all. Thank you so much. Everyone who doesn't know, this is Patrick. Patrick has brought me over here, so a big thank you to you for bringing me here and for making sure I got here okay. What I thought we'd do is we'd start off, I'm just going to show you how I do the eFAST scan. The way I do it is the way I do it for pre-hospital, and the reason I do it this way pre-hospital is because we need to know what's going to happen for making decisions before we start driving in an ambulance to go somewhere. And so that's why I do it the way I do it, and I'll explain as we go. So what we'll do is we'll do it a bit differently. I'll get Patrick to just jump up here. And if you wouldn't mind just popping your shirt off. Yes. So we're going to start with the curved probe first, okay? And we're going to use this for the first thing I like to do, which is the lungs. So I'm going to adjust the depth. Where are we? Maybe I won't adjust the depth. There we go, okay. So the first thing I'm going to do is I'm going to look for the lung sliding for pneumothorax. So I come up here on the anterior chest. And do you see the 2 black things in the top of the screen? The 2 black circles are the ribs. I'm slicing through the ribs, and between them is the pleura. So now we're just going to look at the white line at the top. Deep breath. Fantastic. And breathe again. Everyone see the white line moving? So that's the lung sliding. There's no pneumothorax. So I do that on both sides. Excellent. So now I know my lungs are okay. Then what I'm going to do is I'm going to go for the right upper quadrant, because that's the first point of the eFAST for me. So I come to the right upper quadrant and I make a right angle. Can you hold that for me?
Yes.
Fantastic. So what I'm going to do is in the mid-axillary line, I'm going to draw a line down. And I'm going to find the xiphoid, the xiphisternum. And I'm going to draw a line across. And there is where I'm going to put my ultrasound. probe marker up towards the patient's head, and make sure I have enough depth. So I'll take the depth down to 20 centimeters to give me enough depth to look at. So I come there, and then I point a little bit towards the spine. And there, I can see the kidney and the liver. So the liver is the big round thing, and the kidney is just over there in the corner. So now the kidney is coming into the middle of the screen. Can everyone see the kidney in the middle? Yeah? And the big liver. So can you hold that there? Hold the probe? Yeah. You holding it? Got it? Excellent. Well done. Professional sonographer. So, this is the liver. This white line here is the diaphragm. Can everyone see the diaphragm, the white line there? And this is the kidney. Yeah? Wunderbar.
Marvelous.
Then I come to the pelvic view. Now, I don't want to get ultrasound gel all over his underwear, so we'll see if this will work or not. Perfect. So there we see the urinary bladder, okay? And I go from side to side the whole way through. And I go from the top all the way down. And see how the bladder is like a square? And down here is the prostate. So the bladder is like a square. Then I come up to the left upper quadrant. Now the left upper quadrant is like the right upper quadrant, but it's a little bit higher up and a little bit further back. Usually my patient is on the bed, so I remember hand, bed, head. I take my hand and I put my knuckles like I'm punching the bed, and I move one rib space up towards the head. I start with a right angle. So, mid-axillary line, xiphoid process, that's where I start. Just turn a bit more. So I'm starting over here, and now I'm moving a little bit back and a little bit up. I'm going to see if I can, there we go, cool. So the left upper quadrant is a little bit more difficult. You can see the kidney is over there, and the spleen is over there. And now I'm going to move up one rib space, and point back, and I want to see the diaphragm. Can everyone hear me, by the way? Yeah? So it's important I see the diaphragm, so I know if there's any blood inside the chest as well. So now I've got the right upper quadrant, the kidney and the liver, the bladder, left upper quadrant, spleen and liver. And I've checked not just between the kidney and the liver or the kidney and the spleen, I've also checked the diaphragm. The last thing I'm going to do is the heart. You can either do it with this probe or you can switch to the cardiac probe. In London, there's a lot of stabbings in the chest, so usually this way doesn't work because that's where the stab wound is. Lucky London. So we'll switch to the cardiac probe. Cool. Now, can everyone say this with me? Pop, slide, scoop. And together. Pop, slide, scoop. You're going to find the xiphisternum, the xiphoid. You're going to pop off the xiphoid. Here, I'm pressing against the xiphoid. I'm going nowhere. Pop. Now I'm in the abdomen. I'm going to slide to the right, and then I'm going to scoop. Lean forwards a bit for me. There we go. Okay, breathe in. There we go. So, doesn't look so good when you're standing up, looks a lot better sitting down. Lean a bit forwards. There we go. So I can see a ventricle next to the liver, right? The liver is the thing with the blood vessels in it that takes up most of my screen. It has like a squishy appearance. The right ventricle and the liver are best friends. So you know that the ventricle next to the liver is the right ventricle, which sits at the bottom, and that's where the fluid starts. Thank you so much, Patrick.
You're welcome.
Hand of applause for Patrick. Okay. Thank you. Okay, so where's my clicker? Here. The eFAST. Let's talk about the eFAST. There's two parts. There's the chest part and the stomach part. The chest part is really useful, really sensitive. The stomach part is not as good. When we see it's positive, that's great, but when we see it's negative, we can't necessarily use that to rule everything out. When I'm looking at a patient pre-hospitally, I'm going to package them and put them in an ambulance, which means before I package them, I need to make sure that they're not going to have something that makes them crash on the way to hospital. So the first thing I do is the lungs, because that's the easiest thing for me to fix. If there's a pneumothorax and I see it, I think about it. Okay, there's a pneumothorax. And then I use my brain, because you can only say something is a tension pneumothorax based on your clinical judgment. Tension pneumothorax means that there is cardiovascular instability. They're hypotensive, tachycardic, low saturations. Pneumothorax is what the ultrasound tells us, that there's no lung sliding. Then I go to the heart, because if there's tamponade, that decides which hospital I go to. And then I put the patient in the ambulance, and on the way, I do the abdominal assessment. Yeah? Because if I get a positive eFAST in the abdomen, I'm still going to the same hospital, still going to a trauma hospital. So what are we looking at? We're looking at the lung and the pleura. Is there that lung sliding? Now, if you have a pneumothorax, it's air in the pleura, yeah? The parietal pleura and the visceral pleura slide together. That creates the lung sliding you saw on Patrick's chest. If there's air in the pleura separate. Now you can't see lung sliding. So, I'm looking at the lung and the pleura. I'm looking at the heart. Is there cardiac tamponade? Now, can I see tamponade on ultrasound? Maybe. I can see fluid on ultrasound. And if I see fluid and the patient is hypotensive, tachycardic, there probably is tamponade. I can also look and see what is the heart doing. The heart needs to fill properly. If the right side of the heart, the lower pressure side of the heart, is having problems filling because of the blood around it, because the blood around it's putting pressure on it, I know that there might actually be tamponade. Then we have the diaphragm. If there's blood in the chest, if there's fluid in the chest, it's going to go down with gravity and it's going to sit on top of the diaphragm and squish the lungs. So I'm looking at the diaphragm. Then I'm looking at the liver and the kidney, the rectopelvic pouch, and the spleen in the kidney. Now, none of these cases I'm about to show you are real cases, but they're all based on reality and all the scans are real. So our first case is a middle-aged male. He's 40 years old. He's driving. He's in a car accident. The steering wheel hits him in the stomach. These are his vital signs, okay? So he has a respiratory rate. He's breathing 24 times a minute. His pulse is 80. His saturation is 96. His blood pressure is 120 on 80. So far, dying, not dying. Not dying. We do a clinical exam, head to toe. I put my hands on the patient, and this is what I see. What's this sign called? No, seriously, what's it called in German? Pardon? Brennmarker. Awesome. So in Australia, we'd call this a seatbelt sign. Bruising on the abdomen caused by the seatbelt, or perhaps the steering wheel. Now, knowing this and looking at what the kind of crash of the car was, what percentage chance do you think there is that this gentleman has an abdominal injury, an abdominal bleed? 10%, 20%, 50%, 30%? Anyone else? 100%? No? Good. Cool. Let's give him a good number. Let's give him like 60%. Yeah, let's say 60%, because the seatbelt sign is pretty good indication that there might be abdominal trauma. It's more than a coin toss. So let's say 60-ish%. Everyone happy with that? Yeah, cool. So we'll say 60%, right? Now I do my eFAST. This is the right upper quadrant between the kidney and the liver. Hands up for negative. Hands up for positive. Wonderful. You can see the tip of the liver is swimming in blood. Swimming in blood. There's like a liter of blood in the abdomen. Yeah? So we started off with our 60%, and then we did an ultrasound, we did an exam, a test. And now we have the actual chance of there being an intra-abdominal injury. So we had the pre-test, the test, and now we have the post-test. So if we started at 60%, this is a very clear ultrasound, right? This is a really good chance that if I see fluid there in trauma that much, I'm like, yeah, that's an injury. So there's a very, very high chance, almost 100%, that there's an intra-abdominal injury, yeah? Yeah. What if I take the same patient, the same vital signs, the same clinical exam, the same bruising, and I show you this ultrasound? So hands up for positive, and hands up for negative. Yeah, it's negative. But I start with 60%. Now I've done my ultrasound. Who here thinks that I can totally rule out the bleed, that there's any injury based on the ultrasound? Yeah, you need about a Coke can worth of blood, 200 mils, probably a bit more, to get a positive eFAST. And that's in the right upper quadrant, the most sensitive part of the abdomen. So there can be bleeding, but you won't have a positive sign just yet. It might take half an hour. It might take an hour. There might only be a little bit of bleeding. Maybe there's a tiny, tiny little cut in the liver, and it bleeds a little bit and it stops bleeding. On CT, you'll see it. You won't see it on ultrasound if it's less than 200, 300 mils of blood. So I do my ultrasound. It only decreases the chances very slightly. Does that make sense to everyone? That when the ultrasound is positive, it's strong, but when it's negative here, it's not so strong. I can't say that there's no bleeding. So every single ultrasound test we do has a positive likelihood ratio and a negative likelihood ratio. Yeah? Anyone here heard of likelihood ratios before? No? Who here's heard of sensitivity and specificity, though? Yeah, everyone knows sensitivity and specificity. The positive likelihood ratio is just how we use the sensitivity and specificity to calculate how good this test is at telling me something. It tells me how strong the test is. Can I use this test to make decisions? Is it going to make me do good decisions or bad decisions? Is it really, really accurate, or does it suck? So, I have the positive likelihood ratio above 30. A positive likelihood ratio above 10 is good. A positive likelihood ratio above 20 is excellent. I want to be as far away from 1 as possible. A negative likelihood ratio just goes the other way. I want to be as far away from 1 as possible. So, Here we have the likelihood ratios. You have 1,000 up there, really, really strong, and 0.0001 down the bottom. And that's the same thing. You want to get as far away from 1. So negative likelihood ratios, the more zeros you see, the better it is. The stronger it is at saying there is no disease that you're looking for. Around 1, 2, 3, 4, 5, you're not getting very far. Around 10, you start traveling places. You get to like 50, 100, okay, now we're going places. This is a strong test. So this is how we use the positive and negative likelihood ratios. And you have to use these. You have to know these for each and every test you use for ultrasound, because if you don't know them, you don't know how accurate this test is at helping you make good or bad decisions. So, this is called the Fagin nomogram. It is my favorite ultrasound picture. You laugh because it's not a picture of an ultrasound. This is what I use for all my clinical decision making. I look at the patient and I say, what is the chance of the disease I'm looking for? Is there probably going to be bleeding in the abdomen? And I pick a number based on the science and the research which tells me how common these diseases are. Then I do my test, and then I end up with a number that tells me how likely it actually is. So if I start up here, 0% chance of the disease. Down there, 100% chance of the disease. Okay? 0.6, 60%. 0.1, 10%. Everyone happy with that? Cool. It's the opposite on the other side. They just turned it upside down. Now, 60% chance that my gentleman who's in the car crash, I see the bruising on the stomach, let's say 60% chance he has bleeding in the tummy, yeah? In the stomach. Now, what's the positive likelihood ratio for an eFAST? It's 30. So I draw a line across. And my line shows me this, that there is a 97.5% chance of an intra-abdominal injury. Yeah? That's pretty good. That's very close to 100%. If he's unstable, if a patient is hypotensive and you do an eFAST, the sensitivity is almost 100%. So if someone is hypotensive and you do the eFAST and you don't see anything, probably, but not always, there's no bleeding in the abdomen, it's something else. But if that is the cause, you're really going to see it. It's close to 100%. Now, the negative likelihood ratio of the eFAST, 0.025. If I say I've got 0.6, 60% chance of bleeding in the stomach, and my negative likelihood ratio is 0.02, yeah? So now, starting there, before I went up, now I'm going to do the negative likelihood ratio. %. What does that tell me? It tells me the eFAST cannot rule out bleeding in the stomach. Because 3 out of 10, who's happy to rule out injury with a 3 out of 10 chance that there still might be a bleed that we didn't see? No one, right? 30% chance that I could be bleeding, that's not enough to say, oh, you're okay, yeah, you can go home. 30% chance, if I was in hospital and someone said to me, I don't think there's bleeding, 70% chance I'm right, 30% chance I'm wrong. Come on, that's crap. Excuse my Australian. So we can't rule out the injury, and this is why. So, chest, abdomen. This picture here, is this positive or negative? Hands up for negative. Hands up for positive. Hands up for not sure. Cool. So in the middle of the screen, this is a right upper quadrant. We can see the kidney. Okay? The kidney is the thing with the little pyramids in it. It looks like a kidney if you slice it in half. The liver is the circle thing that takes up most of the picture. This is Morrison's pouch. Morrison's pouch is negative, but there is bleeding. Why? The tip of the liver is the most sensitive and accurate part of the entire eFAST. It is the point where the blood starts in the right upper quadrant. Not Morrison's pouch. It starts at the tip of the liver and then moves around to Morrison's pouch afterwards. So you have to look at the tip of the liver. This is the tip of the liver. It's the deepest part there. It's where the liver tip sits. So all you need to do is just move down one rib space. Here is Morrison's pouch at the right angle. Move down one rib. Here is the tip of the liver. Very easy. Same place, yeah? And there's that tip of the liver shaking at you. So Morrison's pouch, and you just move down one rib space, and you get the tip of the liver. And that is the most accurate part of the eFAST. That is the most likely place to see blood. So, in order of how sensitive they are, the tip of the liver is the most sensitive, then the hepatorenal, Morrison's pouch, then the pelvic view, Douglas pouch in females, or the retrovesicular pouch in males. Then the blood starts to accumulate above the spleen, and only then will it move between the spleen and the kidney. So this is the most sensitive to the least sensitive parts of the eFAST, and that's why I go right, pelvis, left. Because if I start up here and it's negative, and I go down here and it's positive, which can happen, done. I don't need to keep going. It's positive, move on. Do I keep going? Yes, of course. I finish the scan. Do I have to for the information? Not necessarily, no. Once I have the information which helps me make my decision, I could finish the scan. But the right thing to do is to finish the whole scan, make sure I have all the images, because maybe I'll find something else that I wasn't expecting. So scan the tip of the liver is the lesson. This is a 64-year-old female I saw. She's drunk. She was having her friend's best friend's birthday, having a great time. Unfortunately, she had too much wine, and she falls down the stairs. She hits her head. She's unconscious for about 1 or 2 minutes. She wakes up, and now she kind of has pain here. Yeah, like here. Point to the pain. It's here. Where? Here. Okay. So I do my eFAST. And I see this. Hands up for negative. Hands up for positive. Hands up for not sure. I looked at this and I said, what? What am I looking at? I wasn't sure. And I said, I don't know. I don't know. And so I did what the radiologists did. I said it was inconclusive. You are allowed to say that. If you don't know, don't make it up. Just say you don't know. But the professional way to say I don't know is inconclusive. Then it's like, it's not his fault, it's the image's fault. Now, it actually is my fault in this case because I wasn't good enough at the time. See, can everyone see the white line there around the round structure? This is the gallbladder. She had fried chips for the first time in a year. So her gallbladder is making all the bile and everything. It's huge. And it was in a funny place on the liver. I know this isn't free fluid because it's a round structure and the round walls of the structure have white, thick brightness to them. This is also not free fluid because it's a round structure. This is a hepatic cyst. Free fluid has sharp edges, as Dr. Polheim so excellently told you. Organs have round edges. Free fluid has sharp edges. Pay attention to the black, how it makes a pointy, sharp space between the kidney and the liver. Free fluid in the abdomen is sharp. Yeah? Cool. So I have my friend, we'll call him Johannes. Johannes likes to mess around with the wrong crowd. Johannes on a Saturday night is walking, he's smoking and drinking, and he's in the park by himself, and he sees a group of younger people, like 18, 19, and he goes, "Hey, punk." And they take a baseball bat and they hit him in the chest. He didn't deserve it, but like, come on, that was silly, you know. They hit him in the chest. So over here on his chest, he has bruising, and he maybe even has, you know, a fractured rib, very tender, lots of bruising. He won't let me touch it, really. Now, these are the vital signs. The heart rate is 120. The saturations are 90. The blood pressure is 130, and the respiratory rate is 34. What are we concerned for here? What disease do we think he might have? Louder. Pneumothorax? Pneumothorax, fantastic. I'm worried he might have a pneumothorax. So what do? I scan. I take the ultrasound probe and I lie Johannes down on the bed so that this part is the highest part of the chest where the air is going to rise to, right? The air rises, the fluid falls. So I lie him on the bed. This is the top part of the chest. This is where I'm going to scan for, the most sensitive part. And I scan over here, not the breast, just above the third intercostal space, the same place I would do my needle decompression. And I scan. And I can see the pleura, the lung sliding on both sides. So does he have a pneumothorax? Probably not. He doesn't have a pneumothorax there. Maybe he has some somewhere else, but probably not. So again, what is the positive likelihood ratio and negative likelihood ratio of lung sliding for pneumothorax? Positive likelihood ratio is 50 plus. Huge, huge. Some studies say the positive likelihood ratio is 120. Some studies say it's infinity. Okay? The positive likelihood ratio is fantastic. The negative likelihood ratio, 0.02, is also really good. 0.02 is the same as 2%. So my positive likelihood ratio, I want to exclude pneumothorax now. So I'm going to use the positive or the negative. I want to make sure there's no pneumothorax. Do I use the positive or the negative? Negative. If I start with an 80% chance of pneumothorax, I think there's an 80% chance of pneumothorax, and I do my lung ultrasound, now there's a 7% chance of pneumothorax. And that's if I say there's 80% chance of pneumothorax. If I start with a 20% chance that I think this is pneumothorax, then there's a 0.7% chance, less than 1%. To me, that's acceptable. Less than a 1% chance of something is probably acceptable for diagnosis. Let's say I'm sure there's a pneumothorax. I believe that there is a pneumothorax in this patient. You are going to have to show me absolute proof that there is no pneumothorax. I've seen this before. I think it's pneumothorax. 95%. 95% sure that this is a pneumothorax. And I do my test, 0.02. It drops it down to 20%. It doesn't drop it down to 0. What this means is that if the ultrasound shows you that there isn't something, but you are sure that there is something, you still need to investigate, because our ultrasound skills might not be that good, because we're not sonographers, we're not radiologists, we're point of care users. We want emergency diagnoses. They're very good for some things, they're not amazing for other things. So if you're sure there's a disease and the ultrasound doesn't agree, you need something else to help you make the decision. It turned out there was no pneumothorax here, so I put the ultrasound on top of the injury. I put a lot of gel so I wasn't pressing on the actual rib fracture, yeah? That hurts, don't do that. Unless it's your best friend, in which case, push a bit, just a little. So I put a lot of gel, right? Like half the bottle, you know. My friend was like, Aidan, what are you doing with the gel? I'm like, trust me on this. You know, he has to clean it up afterwards as well. It's quite funny. And I saw this. The lung is like a sponge. We can't normally see through air using ultrasound, right? Air is the enemy of ultrasound. The lung is a sponge. I've got the lung sliding at the top. It creates echoes, vibrations. You know how a whale can hear over many, many kilometers? Because sound travels really well through water? Right. So if I have vibrations here, the more water I put into the lung, the more echoes down I get from the pleura moving together. And we call these B lines. They move from the pleura all the way down, and they keep going. And this tells us that there's fluid in the lungs. Not a pleural effusion, not a hemothorax, actual pulmonary edema. There is fluid inside the tissue. Now, if this was cardiogenic, if I had a patient with heart failure and I had these B lines everywhere, this would be pulmonary edema, yeah? So if I see this all over the lungs, they have heart failure, it's pulmonary edema. If there's only this in the one space where I hit him with the baseball bat, what's wrong with the lung? Any guesses? Could be ruptured, yeah? So what happens when you hit someone? What happens to the skin? Swelling. What is the swelling caused from? Edema. And when you see a bruise, what's the bruise? Blood. This is a pulmonary contusion, bruising of the lung. Very common in children with chest trauma. This is blood in the lung tissue, only where I see it. So now I know what the problem is. He doesn't need a chest tube. This stops me from putting a chest tube in. The problem is not a pneumothorax, it's not a hemothorax. He has a pulmonary contusion. What he needs is pain relief. So I can either give him morphium, or I can use my ultrasound to do a nerve block for the chest so he doesn't have any pain anymore. Am I going to teach you that? No, that's for later, okay? But you can do it. You can do an ultrasound block, as Suan was saying yesterday, for the leg, you can do it for the chest. You can almost any part of the body, if you can find a nerve, you can block the nerve. So, the lesson here is use the Fagin nomogram. It will help us be better doctors, better clinicians, and safer, because we get our positive likelihood ratio and our negative likelihood ratio. I put my hands on the patient, I examine the patient, and I come up with a likelihood, then I do the test, and then I know what the actual chances of the disease are. Our last patient, 77 years old, he takes warfarin. He falls down at home. He hits his back on the kitchen, on like the kitchen bench, the kitchen counter, and he falls to the floor. And he comes into hospital with chest pain. What do we think the problem is? Old man, warfarin, he falls, he hits his back, his ribs. What do we think a problem is?
Bleeding.
Bleeding. From where? Is there a bone? What bone is there? Come on, guys. If I punch someone in the chest here, what bone do I break? The ribs. Awesome. So, he might have rib fractures, yes? What am I concerned about in someone with warfarin? As you said, bleeding. So where could he be bleeding into? The lungs, around the lungs, the chest. He could be bleeding into the chest. So he might not have a pneumothorax, he might have a hemothorax. So I do an ultrasound of the lungs up here. Lung sliding, no pneumothorax. Good. Moving on. Left upper quadrant, positive or negative? I know I've given you a still and not a video. Positive, negative. Hands up, positive. Hands up, negative. Negative, cool. Right upper quadrant, positive, negative. You can just see the tip of the liver in the right upper quadrant scan there. Hands up for positive, hands up for negative. Negative, happy. The heart. Is there cardiac tamponade? Is there fluid around the heart? The heart's not being squished. I don't think there's fluid around the heart. So now what I'm going to do is, I was in Morrison's pouch, and I'm just going to move up one rib space. And I'm going to make sure that I can see the spine. Can everyone see the white things? That's the spine. I'm looking through the patient like this. Yeah, I'm cutting into the patient, looking through the chest, liver, into the spine. That's those things. That's the spinous process. You'll notice a difference here. What's the difference? Before, I could see the spine up to the diaphragm because I could see the spine through the liver, but then the lung came into view and I couldn't see anything. The patient breathes, the diaphragm comes down, the lung comes into view, I can't see the spine. Now, I can see the whole spine, past the diaphragm. If I can see the spine past the diaphragm, it means that the lung is not there, because I can't see through the lung's full of air. So what is there if the lung isn't there? Fluid. And free fluid in trauma is blood until I prove it otherwise. This is a hemothorax. This is a positive spine sign, as opposed to this. See how the lung comes down? No hemothorax. Or in medical patients, pleural effusion. Positive spine sign. Where the diaphragm and the liver end, I can still see the spine. There has to be fluid there. That's not right. So examine the diaphragm for pleural fluid. That's why the right upper quadrant and left upper quadrant are so important. It's why I do them early on. Not because of the abdomen, but because of the hemothorax and the pleural effusion, because that's really useful information. Because if they have a pleural effusion or a hemothorax, I can stick 20 needles in the top of the chest, I won't fix the problem. They need a proper chest tube. So the lessons are, the chest is very, very useful to rule in and rule out. The abdomen is only useful to rule in. I shouldn't use it to rule out. Understand the statistical characteristics of each test you use. Understand the strength and the weakness of each ultrasound exam, because each one is different. And use the Fagin nomogram. This is the pocusatlas.com. They also have the evidence atlas on the same website. On this website, they have the positive likelihood ratio and negative likelihood ratio for all the point-of-care ultrasound tests that we do. I do not remember them. I look them up. I save them on my phone for when I need them. Okay? There's enough stuff to remember. We do anatomy and physiology. We have to remember so much. We have to memorize the textbook. That's what our phone is there for. This is the real world. So, I love the eFAST because I understand its weaknesses. It has strengths. It helps me make decisions. It helps me do the right thing for patients, but it also stops me doing the wrong thing for patients. And that's just as powerful. Thank you so much, guys.
Are there any questions from the audience? Okay, so where do you think is the trickiest place to find free fluid? Where is it most easy
Difficult?
to most difficult to detect?
So the place fluid's going to start is the right upper quadrant. The right upper quadrant is also one of the easiest things to do. The left upper quadrant is the most difficult view in the eFAST. A lot of people struggle with it. In a trauma patient, if you can't roll them, sometimes it's difficult. When I have paramedics and they struggle with the left upper quadrant view, I say, if you can't get it, don't worry. okay? If the right upper quadrant you've done, the pelvis you've done, and you can't get the left upper quadrant, just skip. Say it's inconclusive there. Because chances are, unless you actually were injured on the left side, there's a low likelihood that the fluid is going to start there, unless there's a splenic laceration. So the left upper quadrant is what people tend to struggle with the most. Yeah.
Okay, thank you very much for this.
My pleasure. If anyone has any questions, you can message me on Twitter or paramedicultrasound@gmail.com. Get in touch with me on Facebook, etc., and just keep doing what you're doing. This is, Sue-Ann and I have just been saying, we are so excited to see what you guys are doing. This is the future of medical education in ultrasound. No one is doing stuff like this. Like, this is a seriously exciting program. So congratulations to all of you.
Thank you very much. Also for you, we want to thank you very much. And this is the package from Austrian Goodies from this region.
Thank you so much, guys.
Okay, so now we'll directly start with the workshops. There is no break in between. And please, for Group A, you're the first for doing the central venous line workshop, ultrasound guided. Please go to the E2 room directly. And and Group A can go with Lenny right now. And Group H is the first for doing the cardiopulmonary resuscitation, and you have to go to the E2 room. Yeah, please. It's the same direction as they are going, so you can just go with them. E2. And for all the other groups, you'll find the lists outside on the walls, on the pillars, and there's written on where the groups are located in which room. And for the lunch break, it's from 12:45 to 13:45, and your tutors will give you coupons for the lunch, for the Mensa, and everybody who knows the Mensa can just then go there and eat and come back at 13:45. And for the few people who do not know where the Mensa is, just follow your tutors, they will show you. Okay, so enjoy the workshops.